Today we will be discussing a case of warfarin toxicity. So, may I start?
Yes.
So, a 41-year-old male was rolled into ER with alleged history of consumption of warfarin tablets in addition to what he usually consumes. So, initial 10 seconds.
He's already on warfarin. No extra tablets he has taken.
Yes. Initial 10-second assessment. Patient was conscious oriented and he could speak relevantly in full sentence. Coming to primary survey. Patient's airway appears patent. There was no signs of any airway obstruction. Coming to breathing, patient chest movements were equal bilaterally. Saturation was 99% in room air. The respiratory rate was 16. There was no respiratory distress or tachypnea present. Coming to circulation, his blood pressure was 150 on 80 millimeters of mercury with a pulse rate of 70. Peripheral pulses were well felt. Coming to disability score, he had a GCS of 15 on 15 with a GRBS of 130 milligram per deciliter and pupils were 2.5 millimeter bilaterally equally reacting to light. And exposure part, he was febrile and there was no signs of any external bleeding present. And at this point, he seems to be stable.
Warfarin will produce what all types of bleeding?
Minor bleeding manifestations.
External bleeding you check, that's okay, but it's not enough.
Internal bleeding.
Internal bleeding we cannot see, but external bleeding means you have only seen the skin. What else you have to see?
Oral mucosa,
Oral cavity,
gums, bleeding, eyes, conjunctival, subconjunctival hemorrhages.
Fundoscopy. All these things should be done to complete the examination. Okay.
So, coming to after the primary survey, the patient there was no immediate emergency measure to be taken in stabilizing the airway breathing because he was conscious oriented with no airway breathing compromise. But he had a history of consumption of about 17 tablets of 1 milligram each warfarin and 1 tablet of 3 milligram of warfarin. 20 milligram warfarin.
What was the strength he was taking?
He was taking 3 mg, 3 mg, 3 mg, 2 mg like that.
Okay. So, and on an average 3.2 milligram.
So, at this point, he had taken this warfarin tablets about 30 minutes before coming to ER. So, we had gone for a gastric decontamination. So, we had put a Ryle's tube and tried to aspirate the contents and also given a gastric lavage, and we had also given him.
Normally, Ryle's tube aspiration will not work. That we should know. Okay. Just for our satisfaction, we may be putting, or to take a sample we are taking. But for a toxicological purpose, it will never work. Okay.
And we had administered activated charcoal 50 mg through this Ryle's tube. After this, coming to the sample history, the patient has no history of any allergies. The patient, is a non-case of rheumatic heart disease, status post mitral valve replacement, and he is on warfarin. And he had a previous history of atrial fibrillation with a controlled ventricular rate, and he also has a previous history of CVA about 10 years back. And he is also a non-case of OCD, and he is on clonazepam tablet for that. He is other medication. He is on penicillin as a prophylactic dose, and Pendrits. Okay. And he is also taking CCBs for antihypertension as an antihypertensive drug.
Do you think that the CCB here, what CCB is taking?
Cilnidipine.
It's taken for hypertension.
Okay. These are his drug history and previous history. So, the events leading to this is that patient, he's alcoholic and had consumed alcohol that day. After that, he had taken this 20 milligram of warfarin deliberately as a deliberate self-harm.
What do you mean by OCD, obsessive compulsive disorder?
A patient repeatedly does a thing, like repeated checking. It can be a pathological like doubt is the main thing.
So whether this drug taking is a part of OCD or
No, it was not like he had like taken a medicine, suspecting a missed drug. He had not taken like that. He had deliberately taken it
to suicide.
To suicide.
With suicide
intention. So that is the events leading to the history. And coming to the secondary survey,
for that, whenever somebody is on warfarin, on multiple drugs, what are the important things you want to check before doing anything else?
Drug interactions with warfarin is important.
All drug interactions should be checked, whatever drug he is taking. All the food interactions should be checked, whatever food he has taken. All these things should be taken into consideration before treating the patient.
What is the role of alcohol here? He has consumed it along with alcohol. So what is the interaction with alcohol and warfarin?
He has like yesterday he had consumed alcohol and this day he hasn't. Okay. But the gastric absorption can be like more.
No, what will happen to a patient who has consumed alcohol and he has taken warfarin? That is my question. Whether the metabolism will be same or metabolism will be delayed, or whether the level of warfarin is going to be high. All these interactions you know. So either the warfarin level will go up or either warfarin level will come down or the metabolism will take a longer time.
Like warfarin alcohol interaction, there is like not much.
See, there can be some interaction, but it is not at all predictable what exactly happened. It can sometimes increase the metabolism, sometimes decrease the metabolism also. It is not predictable. So what else this patient is already an alcoholic? Whether this patient is having a chronic liver disease also associated with this. So what will be the presentation right now? He is already having a CLD with warfarin overdose.
Then INR, like already CLD causes coagulopathy. Vitamin K dependent factors will be low.
That is one side. What is the metabolism of warfarin?
Hepatic metabolism will be there, so
Okay.
so metabolism will be delayed.
C450 metabolism
So
for warfarin.
So metabolism, hepatic elimination, so it will be delayed. So it will be more time. It will stay in the
So
blood.
that is an important thing. So here the main problem is usually the drugs either renal or have metabolism by the liver. So here is a liver metabolism. So the problem is that once this patient is having a CLD, underlying CLD also, the action of warfarin will be prolonged. Usually what will be the half-life of warfarin?
Warfarin about like 72 72 hours. Sorry sir, I'm not sure.
Somewhere around 36 to 72 hours. That's what the usual warfarin half-life. Usually the peak action will come within 12 hours. 12 hours the peak action will start to come. But in this patient you have to think that his warfarin action will be prolonged for some more time.
What is the action of alcohol on the heart?
It can cause like sympathetic like tachycardia.
What arrhythmia is common in alcoholics?
Atrial
fibrillation. Atrial fibrillation is one of the most common arrhythmia which can occur in alcoholic patient. This patient is already having atrial fibrillation. There is a high chance of increase in the atrial fibrillation. That also should remember.
So after this sample history, systemic examination also reveal nothing significant at this point of time. Coming to like the initial management, like after the gastric decontamination and we have taken the sample.
Sample for?
We don't know if any coingestants are also there, and we have also taken a baseline PTINR at that point of time, and like a baseline. We have also sent the blood level for warfarin for analysis and other routine blood investigations as a part of.
What are the toxicological investigations that you have sent from the gastric aspirin? See here, whatever decontamination you have done is not good, because whatever is done is not going to help. You have to either do it a proper gastric levels too. That's what SRS mentioned initially. Only rise to you can two things that will help. To take an aspirin and to give activated sulfur, because its palatability is very poor. So you can give via RIS2. So what all samples you have asked for? What all tests you have asked for in the sample gastric aspirin?
We have asked for like any look for any co-ingestants like any rodenticides or any like pesticides and all, and the routine toxicology panel.
You have basically asked for a screening for what all things is there in the gastric aspirin. Okay. So always remember co-ingestion. That's exactly what you have done. Okay. Continue.
Initially the INR was 2.6 2.03 and other parameters were also within.
So what was the previous INR and what is the expected INR for this patient?
Target is like 2.5 to 3.
No, valve replacement.
Medtronic valve.
3.
Okay. So his INR previously was also like it was fluctuating only. So last value in last visit was 2.8.
Okay.
So after that doses were adjusted, but like the values always show a fluctuation is what from the history we got.
Okay.
So
what are the reasons for fluctuating INR like this?
maybe because of drug drug interaction, food.
Food, okay. But what is the most common cause for fluctuating INR in investigation? It's different labs. So always think that whenever we are asking for PTNR, it has to be done from a good lab, but you have to continue the INR in same lab. Wherever you are doing, the patient is doing. But if you do in different labs, most of the time this type of errors can occur. And so we advise the patient to do INR in a particular lab only, or he is coming here every time he is coming here only in this lab. We should not tell the patient to get it done from different labs. Okay, there will be slight variation.
So after this, we have admitted him to intensive care unit and for monitoring with the intention of monitoring the INR every 6 hourly, and also to look for any signs of bleeding. So till now, like his INR has elevated from this 2.03 gradually to 3 to 6 to 7 and then to 9, but he has no features of any bleeding so far. So since the INR is between 4.5 and 10 and he is a high risk of bleeding because of the previous history of stroke, we have given him oral vitamin K, 2.5 mg has been given.
What is the difference between oral vitamin K and IV vitamin K? Is there any difference?
IV vitamin K can be more irritant.
Which one will be more effective?
IV will be
availability wise, it both may be same. But already somebody is having liver disease, then absorption may be delayed. It's better to give IV vitamin K than an oral vitamin K in this type of patients, because it has got a more predictable action.
This patient till now he hasn't developed a bleeding manifestation, but we have kept in reserve FFPs arranged, and for in case of a severe bleeding manifestation, we will have to go for either FFP transfusion or for factor PCC transfusion. We will have to go for.
Why do you want to give FFP in this patient?
Basically, the factor deficiency will cause the coagulation. So they'll give the factors, the coagulation pathway can be better.
Okay. What are the problems of FFP giving in this patient? Why don't you give in this patient? Why you are not giving?
FFP is indicated in patients with a severe bleeding or more than 10 with a severe bleeding.
Somebody who is not having this valvular replacement,
here the problem
definitely will give FFP in this patient.
Here the problem is reversal of anticoagulation can lead to a stuck valve.
Okay.
So that will be a more harmful problem.
Okay.
So in this patient, since he is on therapeutically on warfarin, the INR level when we are reversing the coagulation, reversing the anticoagulation, we will have to be more careful because stuck valve is a complication.
Okay.
That is why we are more concerned about this patient.
Okay.
How will be the stuck valve present? The patient is in your ICU. You started collecting. What will be the clinical presentation of stuck valve? How do you diagnose stuck valve?
On auscultation, usually there will be a valvular click, mechanical click will be there. That won't be there in a stuck valve.
Okay. Clinical presentation, what will be the clinical presentation?
Stuck valve is what? What is stuck valve? This is
mitral valve won't be working.
So what will happen? Mitral valve works in between
left atrium and the left ventricle.
Mitral valve does not open. What will happen?
Left ventricle filling won't be
there. Left ventricle filling won't be there, but left atrium
enlargement.
distension. That pressure will go to
lungs.
Lungs. So what will happen?
Overload and
So pulmonary edema or
overload.
breathlessness is the most important. Acute breathlessness is the most important. That valve sound and all, I don't know how many doctors will can pick up. Okay, and some newer valves will not have that much sound also. So that is okay there. It can be missed, but the most important clinical finding will be acute onset of breathlessness. Okay, that should be taken care.
Which all factors will be affected here? Vitamin K?
2, 7, 9 and 10. Other 2, 7, 9, 10 will be the
Protein C and
protein C and protein S also.
Okay.
So they both have a thrombotic effect, and these 2, 7, 9, 10 will have a anti-thrombotic effect.
Anti-thrombotics. Okay. So we have an option of not giving FFP. What are the other options that is available?
Prothrombin complex concentrate, that's a PCC, 4-factor PCC are there, or 3-factor PCC. And if not available, we can also give a recombinant factor 7. These are the other available things.
Why this INR took time to increase? Why you think the initial INR was 2?
Yeah.
It was 3. Why it is taking time to increase? What was the second reading taken after how long?
After 6 hours,
6 hours.
it was a 3 point.
Why you take 6 hours to redo the test?
What is the idea behind it? You just come at 0 hours. You send a sample at that point of time. Then you send it after 6 hours. The question is why it was taken after 6 hours?
Because these factors will take 6 hours. It's the half life.
Okay.
It will
So
get
reproduce. Okay.
So only if anything is happening, it will
After 6 hours only evident lab wise evident INR elevation can be decrements can be there only up to 6 hours.
That is the reason. Again, 12 hours is the peak time for your warfarin.
Okay.
So the maximum effect you are going to anticipate is after 12 hours. And which is the most factor important for the PTNR? You say 2, 7, 9, 10. Which is the most factor that is determining the INR? Which factor? Factor 7. Factor 7 is more determining the INR. So factor 7 has to decline. So factor decline up to 50 to 40% decline only the INR will start increasing. Maybe 30%. So 30 to 50% the factor 7 has to decline. Then only the INR will start elevating. So that is the reason. So the factor 7 is more dependent on INR. Okay.
What happened to this patient afterwards?
Right now, he's in the ICU. His INR it has gone up to 9, and today yesterday's value it was 9. Today morning value it has come down to 7. There is no evidence of any bleeding so far, and other vital parameters are stable.
Okay. Patient is stable now. What is the INR current INR?
7.
7. Okay. Now what you will do?
We have withhold all the warfarin, and we have already started him on vitamin K. And if the INR is coming below 5, we will be stopping the vitamin K. And once it reaches the therapeutic range, we can restart on warfarin.
What are the other things you have to do for this patient?
We have given a psychiatry evaluation for the patient
Okay.
and a consultation, because it is a case of deliberate self-harm, and he has already a previous history of OCD.
Okay.
So any psychiatric evaluation was done, and when we are discharging the patient, we'll have to look for any drug interactions, if any, and accordingly.
Whatever drug written by psychiatrist, again you have to go for drug interaction and check it. If there is an interaction, we have to inform the psychiatrist also. Okay. Thank you.